Today I'm going to talk to you about the recognized that is directly related to climate change. I'm going to tell you the story, the detective work to try to figure out the cause, and hopefully you'll find it interesting and also enlightening, because as we move forward, we're going to need to start thinking about this more and more in the patients we see. My disclosures are here. Nothing is related to my talk. So, around the year 2000, a medical student named Ramon Garcia was working in El Salvador at a hospital called Hospital Rosales. He was working on a ward where it was filled with patients with kidney failure. And they were all young. Basically everyone in the group of those patients, most of them were in their 20s and 30s. And it was supposed to be a cardiac ward, but it was filled with patients with kidney disease. And so he said to his attending, Ricardo Leyva, he said, you know, why do we have so many patients with kidney failure that are so young filling up our ward? What's happened? He says, well, it's been that way for a few years, and I don't really know. So Ramon went around and talked to patient bedside and tried to get histories, and he found that the vast majority of them were coming from a particular region in El Salvador along the Pacific coast. And many of them were rural agricultural workers. And he wrote his first paper with Ricardo, pointing out that perhaps there's an epidemic going on of kidney disease among rural agricultural workers in this region. And he thought it must be a toxin. Subsequently, epidemics like this started to be reported throughout the world, but particularly in Sri Lanka, in India, in Mexico, in Thailand, in Sudan, and even there were reports in the US. And what we now know is that there is a huge epidemic going on. Oop, did that change on its own? I think it did. And they're pretty much affect young people, usually sugarcane workers, but they can be other types of farmers. They're working out, in extreme conditions. It's usually very hot. Most of them have spent 5 or 6 seasons working. And so this is the group that we're talking about. Young people, healthy people, athletic people, developing kidney failure at age 22, at age 25, and being dead by the time they're 30. So, as I mentioned, sugarcane is the most common occupation, sugarcane workers, especially sugarcane cutters. But there are other occupations. Some of them are cotton farmers. Some of them work in construction. Different groups, but the vast majority are working in agricultural communities in the group that are suffering in South America. They present with just an elevation in serum creatinine, and the vast majority don't have any symptoms. And so because it's a kind of a heralds what's going to come forward, when people every season, before they go out and start working the sugarcane fields, the owners of the sugarcane fields will screen the workers. And if you have a serum creatinine, you don't get picked. You can't work for them. And this is the only job they have, and it's a disaster if that happens. And if you do get the kidney disease and you end up dying from it, the family usually relies on the oldest kid to take over. And they fake their age, get in, and they start working at age 14 in the fields, and then they develop kidney failure. They die when they're 22. And so what we're seeing is a terrible, terrible circle of death. And the place is called, these regions are called the land of widows, or the island of widows, La Isla de Viudas, because it's a very bad situation, and it's the only job, and the people are depressed, and there's very few doctors. There's no dialysis available. There's no transplantation available. It's a death sentence. This is a big deal, okay? 60,000 people have died and more. And they, as I mentioned, there's some unusual aspects. You know, when we get kidney failure, we usually have a high potassium. These guys have a low potassium. These people often have high uric acids. And it's an acute presentation. Sometimes they'll come into the emergency room really sick with a kind of an acute inflammation, fever. If they get biopsied, they actually have what looks like acute tubular interstitial nephritis. But most of them, it's kind of an asymptomatic, slow rise in creatinine. Then they start feeling tired and weak, and then they just collapse. They can't work. They get kicked off. They get fired, and they die. It is an epidemic. They've been able to look back, and you can actually show that in the regions where this disease is occurring, that it is something that began in the 70s, and it's been increasing progressively. The same was true in Sri Lanka. It's in a certain region of Sri Lanka. It's in the northern sector, hot area. It began around 1975, 1980. So it is an epidemic. It's mainly affecting the workers, the men, but there's some evidence that even the kids and women who are not working in the fields may be getting some disease, but for sure the women working in the fields are getting this disease equally. In India, you know, every place calls it, you know, they name it after, you know, so first it was called sugarcane nephropathy, and then Mesoamerican nephropathy. In India, there's a region called Udinam, so it's called Udinam nephropathy. But the diseases look, again, it's almost the same, but in Udinam, it's mainly among rice paddy workers. And the same is true in Sri Lanka. It's the same story, and the disease is probably the same. And again, it's mainly seen with rice paddy workers. So now we have an epidemic going on. It's killing people. They feel extremely sorry for their circumstance. And we want to know what's causing this disease. They don't have hypertension. They don't have diabetes. They don't have glomerulonephritis. They don't have obstructive kidney disease. They don't have polycystic kidney disease. So we call it chronic kidney disease of unknown etiology. It's something different from what we're seeing here, or is it? But we are not typically seeing people who are not diabetic. You know, our one cause of kidney disease, you all know it's diabetes and hypertension. That's not what's going on here. And they have figure out. They have what's called chronic tubulointerstitial nephritis. They have chronic scarring of the tubules and fibrosis, and there's some inflammation, and the glomeruli can be involved. The filters, the glomerular filters, can be involved. You can get some sclerosis, you can get some wrinkling. Some of it looks like ischemia. But we don't see immune deposits. We don't see anything that we can say, aha, this is X. And I mentioned the outcome is bad. The mortality rates there are 10 to 50 times higher than here for kidney disease. It's the highest rate of kidney disease mortality in the world if you are unfortunate and live in one of these little villages. And I've gone out to these villages, and I've met the families, and I've talked to the bereft wife, and this is something that is a very important disease. Okay, so now we're going to explore. We're going to become detectives. We're going to try to figure out the cause, and it's an exciting story, but let's take us through it. Well, probably the first thing that, I think of is climate. These guys are working in a very hot environment, right? And we know that climate's getting warmer, so perhaps we've crossed a threshold where they're now, oh, I don't know what's going on here. Let me see if I can move it back. It's moving forward on its own. So the temperatures are increasing. But what's interesting is that although climate change is occurring, it's only been like an increase of 1 degree, maybe 1.5 degrees, in the last 100 years. Is it enough to suddenly cause an epidemic like this? Well, you wouldn't think so, except that when you change the mean temperature by 1 degree, the ends of the Gaussian curve spread much more than you think. And so what's happened is climatologists have been able to show that a 1 degree change in temperature can account for a 75% increase in heat waves because of this extreme phenomenon. And so heat waves are much more likely today to be due to climate change than anything else. And heat waves are an issue. And heat waves can kill people. They can lead to heat stroke and mortality. And 2 of the greatest fatal natural disasters were these heat waves. And there was one in Europe in 2003. It was horrible. But we've had bad ones in the last few years. Temperature, this is a heat index which includes humidity, and my God, it hit 165 degrees in Iran. That is like ungodly. And that is not the record anymore. And water shortage is happening too. It's scary, but palatable water, really important. Serious water shortage is happening. It's continuing to increase. It affects 10% of the world population, and modest water shortage shown here, and it's like 40% of the world. So we don't have enough water. Things are getting hotter. Heat waves are going, and that can lead to heat stroke. And heat stroke, just to remind you, is when you cannot control your body temperature. And your body temperature classically goes 40 degrees centigrade, or about 104 degrees. And you can't control it. Your body shuts down with the fevers that high. You can become confused. You can get coma. You can get a multi-organ failure, liver failure, kidney failure, seizures. This is what's killing a lot of people with these huge heat waves. They come in. There's two ways you die from heat shock. I think you probably know that. There's exertional heat shock. That's the guy hiking in the Grand Canyon without enough water. That's the military group out in Afghanistan that gets working too hard in the heat without protection. And then there's kind of non-exertional heat stroke, which is that little guy, that 80-year-old guy who's in that house with no air conditioning when a huge heat wave comes and he can't get out of his chair to get water. So there's 2 types of heat stroke, classic and exertional. Now, recently, this really come to bear on the Nepalese. I have a Nepalese fellow who went on to become an academician. And we've been involved in a very frightening thing. In Nepal, one of the greatest ways you make money, a major mechanism for work, is to be a migrant worker. And you get a full health checkup, and then you go to a country and you work for a year or 2, and then you come back. They don't let you leave unless you have normal kidney function. But they've been seeing a tremendous number of people coming back, 20 years old, with kidney failure. The dialysis units are filled with people coming back from Qatar and Malaysia. And a lot of them went to Qatar for the World Cup, and they were out there building things in the heat. This is a study. Oh, this is a study of Qatar workers from Nepal that are from Nepal, and looking at cardiovascular mortality. These guys are like 40 years old. I mean, and they're dying of sudden cardiac death, and you can correlate it, the CV mortality in red, with the spikes in temperatures that are occurring in these people. I mean, in Qatar. Isn't that something? It's hotter, and you're working outside. You can die from heart disease and stroke, even when you're pretty young, even when you're really young. Miners can get into trouble. You know, like in South Africa, it was known back in the 60s that if you were a miner and you were going deep into the shaft, that it was very hot down there, and it was not uncommon to get heat stroke. And there's, these cases, like this 35-year-old guy, South African miner, temperature of 106, goes into kidney failure, gets put on dialysis. He has a biopsy. It shows acute inflammation. He survives on dialysis, and then he recovers, but ends up with chronic kidney disease. And if you look at the heat stroke, they get hypokalemia with kidney failure, hyperuricemia, some of the same things we see. Some of them get rhabdomyolysis. We don't really see a lot of rhabdo in these guys in the field. We see what we call subclinical rhabdo, but could it be repeated injury? And interestingly, if you recover from heat stroke, there's now data that you're at risk for chronic kidney disease. 4-fold increased risk for chronic kidney disease, 9-fold increased risk for end-stage renal disease. If you go in this study from Taiwan, if you just show up at an ER complaining of heat-associated problems, heat stroke is associated with cardiovascular disease and kidney disease in the 10 years following. And look, or 14 years following, and even if you just have a heat event, you got to get hydrated for a heat event, you're at increased risk for developing chronic kidney disease. So this raises the question, could recurrent heat and heat waves cause either clinical heat stroke or maybe subclinical heat stroke that then leads to chronic kidney disease? And could climate change be associated with this epidemic? So we were one of the first groups to actually look at this. And I became interested in this, and I started Googling, where the hottest regions of, were in Central America. And by God, the areas that were the hottest were the areas where the epidemics were being reported. Exactly. It fit like a glove. And actually, you can probably see that in Guatemala, there's a red stripe there. We predicted there would be an epidemic there, and there is. And actually, we're studying that epidemic. And also, I looked up these, where heat waves were occurring in India. And there was a pretty good correlation. Andhra Pradesh, Odisha, Akiola, are all sites where the epidemic's been reported, but it's also been reported in Goa. And Goa's not perfect. There's maybe something more. And if you look at the sugar plantations like in Nicaragua, it's the sugar plantations on the coast where it's hotter where we see the disease. But sugar plantations at the higher altitude that are seeing the same chemicals, it's much less common. So it correlates more with temperature than with agrochemicals. And then epidemiologic studies started looking at it, and they could not link it with chemicals. One study linked it a little bit with paraquat, but mainly it correlates with heat. And in fact, when you look at what these guys are exposed to, the OSHA, or Occupational Safety Health Administration, has standards of what they consider as too hot or not. And they call it a wet bulb temperature to get this heat index score. And if you go over 30, if the temperature index is greater than 30, you're only supposed to be out there like 25 minutes or 15 minutes for every hour. Well, you hit that by 10 a.m. So these guys are going into work at 5:30 in the morning, and they leave around noon or 1 p.m. because it's too hot. But they're actually working when it's no longer safe to work. And they have to because they're paid for how much they cut. So some of them do present to the emergency room with acute injury. You get this inflammatory response. It's not ATN, it's AIN, or acute allergic, it's sort of allergic interstitial nephritis, and they get white cells, leukocytosis, CRP goes up, urine leukocytes are present. We found that there's a simple test called the neutrophil lymphocyte ratio. You can measure in the blood, and that's really high. And this correlates with this illness. But then over time, they developed this chronic tubular interstitial disease. And remember that miner? This is his biopsy on the right. He actually, it looks the same. So it makes you wonder, could this be a heat mechanism? Well, how would it happen? Well, one mechanism could be simple. They're out there working hard. You might get a little bit of subclinical rhabdo. The CPK goes up a little bit. The DNA and and RNA from the injury goes to the liver, gets turned into uric acid, and uric acid goes up. And this, if you take these people and these workers and you measure their blood before, if you measure the blood before they go into the field and then after they come out of the field and you measure the urine, you can show this rise in CPK, you can show a rise in creatinine, you can show a rise in uric acid just in the 4 hours they're out there, or 6 hours they're out there. So maybe it could be that simple. And because they build up some lactic acid from working, their urine pH drops, their serum lactic acid goes up, and a low urine pH coupled with a high uric acid can lead to crystalluria. And we see crystals in the urine in about 15% of these people. But one day, so we're getting these samples, and we're finding like 15% of them have urate crystals. And we think, well, maybe it's crystalluria. Maybe it's subclinical rhabdo that's causing this injury. And so we were working with 20 workers, and we would get their urines from the morning and afternoon. And one day we got this sample sent to us from El Salvador, and it was only 8 samples. And the guy says, we weren't successful in getting 20 today. I would just ignore this and just work with something else. But I asked my friend and brother-in-law Carlos to measure, who works with me, to look at this. And anyway, and he comes back and he says, all 8 of them have the incredible amount of urate crystals. And when we measured the uric acid, it was like a tumor lysis-like syndrome. I'm going, well, how could that be? That night I went home and Googled the date that they sent it to us, and it turned out that was the hottest day in the year, that year, in that area. And I realized, this was a heat wave, and they weren't ready for it. So they didn't bring enough water, and I found out that the reason there were only 8 people was because the other ones left early and didn't want to participate in the clinical study because it was too hot. And so I realized that it's the heat wave that's doing this. And maybe that's the mechanism. So we wanted to test for that because no one's ever really shown that chronic heat exposure causes kidney disease. So Carlos decided to take mice and subject them to putting them in a heat chamber. And they would 30 minutes, and then they would come out, rest, relax, and then go back in. One of them got to drink every time they came out. The other group had to wait till the end of the day, like eight episodes, and then they could drink. Interesting, both groups drank exactly the same amount of water over 24 hours. But the water was delayed. And when we did this, we found that delayed hydration was associated with kidney disease. The animals developed chronic kidney disease, elevated creatinine, fibrosis, tubular interstitial disease. And the animals that got to hydrate right away were protected, even though they're drinking the same amount of water. So then we realized that these sugarcane workers are out in this open field. There's no shade. They're taking enough breaks. So working with several groups, we helped establish a hydration program where they were canteens so they could drink while they worked. They ended up not liking that. But we ended up bringing tents. They tents out, and then when they cut the sugar cane, they move the tent so they have this shade they can go under. And so we started doing that. Now, really look at this, we wanted to see what happens if the body temperature is a little bit higher. And it turns out that your body temperature is regulated by your mitochondria. And there's this thing called coupling. And if your mitochondria are uncoupled, instead of generating ATP, they generate more heat. So some people have uncoupled mitochondria, including mainly Hispanic people, whereas other people have more coupled mitochondria, like African Americans. And it was interesting that the disease is more common among the Hispanic communities than like in Cuba among the African American genes. And so what we did is we took a drug that can uncouple the mitochondria, and we gave it to our mice, and that made it a higher body temp. When they got the higher body temp to the same heat exposure, they had worse disease. And we thought, well, could there be other mechanisms besides heat and subclinical rhabdo and uric acid? And we realized that when you get dehydrated, you stimulate vasopressin. And I'm not going to go through it, but chronically elevated vasopressin can also cause low-grade kidney damage. And also, when you get dehydrated, you activate an enzyme called aldose reductase that generates fructose. And turns out that fructose, when it's metabolized, drops ATP level, can cause injury in tubules, kidney tubules. And so we wondered if the fructose might be playing a role in the kidney damage as well, and block the damage by preventing fructose metabolism. So we think that these pathways are important too. Well, the reason fructose it's important to know that is that a lot of people get big exposures to fructose by drinking soft drinks with high fructose corn syrup. And we got these reports that some of these workers aren't drinking water, they're drinking Coca-Cola when they're out there working in the fields. So we did studies in animals where we rehydrated them with soft drinks instead of water. And we found that when we did so, we could actually make kidney disease worse. Whereas, you know, if we did like stevia water or something, we didn't see that. So we have all these different mechanisms for how kidney injury could be developing with high temperatures. And, you know, some of it is through fluid and electrolytes, some of it's from high fever and high body temperature. And exactly which one is really most important, we don't totally know, but we do know that if you hydrate people and give them shade, you can reduce the kidney damage, and this has been done a variety of ways. If you drink the usual way, your creatinine is going to go up much higher, and if you hydrate more, you can block. But there are these data like here where people are fully hydrated, they get shade, and there's still some kidney damage. It's not perfect. And it raises the question that there might be something else driving kidney disease. In fact, in this particular study that was done in Guatemala, 500 sugarcane workers, they're drinking 15 liters a day. They normally would drink 5. And we're not seeing too many dehydrated ones, but there's still a lot of them developing kidney injury. So there's something else besides heat. Could there be a toxin that we don't know about? So we've been wondering about that, and one of the things about sugarcane workers is they burn the fields before they cut the cane, and the burning the fields, you know, scares away the rats and the snakes, and it gets rid of the green leaves, and But the cane stays, and then you can cut the cane, you can still get the sap. So these guys go out there and the fields are hot. They go out there after the sugar cane's burned, and guess what? They get exposed to a lot of ash, sugar cane ash. I've gone out there and you cut the cane, there's this huge release of ash from the cane, and none of these guys can want to wear a mask because it's so hot. So they're taking this ash up. And when you look at what's in the ash, there's this stuff called silica that makes up the majority. And they get coated in this ash. The ash coats their body, it gets on their water bottles, it percolates down into the groundwater, and they're just exposed to it. So what exactly is this silica? Well, I think you know that there's a disease called silicosis, which is you inhale silica crystals, like from sandblasters. And the crystals get in the lung, and they cause inflammation, and they get you. You know, you get this terrible lung disease. But these are silica nanoparticles. They're like much smaller, and they pass through the lung. But guess where they end up? They can end up in the kidneys. And they're in the groundwater, and you can see it here from the groundwater from the ranches where the sugar cane plantations are. So we decided to give sugar cane or silica particles to animals. We gave them sugar cane ash, and they started developing chronic kidney disease that also looked very much like what we see in the workers. So we decided, well, can we prove if silica is causing kidney disease among the workers? So I found a toxicology group. They're fantastic people. And they had this ability to look for toxins in tissue using a thing called mass spectrometry. And we worked, and it took us a long time, but we figured out how to measure silica nanoparticles in biopsies, kidney biopsies, just tiny little slices of tissue. And it took us a while to figure out how to do the denominator, because you have to know how much tissue there is, but we figured out how to do that using image software. So now we could actually come up with a number for how many silica nanoparticles there are in the tissue. And we found that when we looked at sugarcane ash, it had a signature. Most of the nanoparticles were around 200 nanometers. And in kidney biopsies from patients who didn't have this disease, we didn't really see silica in the biopsies. But when we started looking at the biopsies of patients with kidney disease that were of the unknown origin, we started finding this. And what we have here is unpublished, but the paper is in press. First study showing that these patients, a lot of them have high silica in their kidneys. Now, not all of them do, but we also know that when we give silica to a rat, that over time the rat will get rid of the silica, but the kidney disease continues to progress even when the silica is no longer there. So it's very suspicious. We've now seen it in El Salvador, and we've seen it in Mexico. We have a grant to look for it in other sites. And this is in Mexico. We're finding high silica in the drinking water. We're finding it in the biopsies. And so we think that this is another mechanism. So now we have two terrible things going on. We have a heat stress, which is clearly predisposing to kidney disease, and we have a toxin. And we're going to see more of these kinds of diseases in the future. And everyone needs to be prepared for this. My prediction, and it could be wrong, I've been wrong, but I think 50 years from now, we're going to have diabetes and obesity totally handled. And we're going to be looking at what toxins in our environment are doing, what climate change is doing. And so be prepared. We need more people to do this. At the University of Colorado, we have a Climate and Health Foundation. We have a climate fellowship program. We are training doctors and PhDs in climate medicine because we think it's coming. It's going to be the next major wave. And we can also put the silica on proximal tubules cell culture and show changes as well. And then when we look at the release of the biomass, we can see that when the epidemic was reported is when most of the sugarcane burning was at its peak. And it's a trifecta. If we get them to quit burning sugarcane, we may actually save lives of the workers. Victory one. We're going to reduce biomass and reduce climate change. 15% of the world's climate change is from the release of burning masses and stuff, burning fields. We're going to help climate change. And we're going to increase the cost of sugar, which is going to reduce the levels of obesity. So, in conclusion, there are epidemics of chronic kidney disease that are occurring in rural communities throughout the world. They're now being reported in Florida, in California, in Central Valley, in Texas. It's coming. It's probably it can probably add to disease that's occurring in a diabetic or a patient with hypertension. We're now seeing heat stress being associated with worsening diabetic kidney disease. So it can affect anyone, and maybe it will worsen existing kidney disease. We know that heat stress and dehydration are a major component, but there could be toxins. Silica just may be one of them. Obviously, it's still very preliminary. There's nephropathy, but maybe there is. And so that ends my talk. Carlos is it's nepotistic, I think, but he works with me. He's a brother-in-law, my brother-in-law. Jared Brown, the toxicologist who's really figured this out. Josh Schaefer. Good question, because these silica nanoparticles, some of them are too big to get across the basement membrane with normal permeability. However, if they get into the mesangium, they could theoretically break through the paramesangium to get into the urine. There's a little bit of hematuria and leukocyturia that's seen. We are going to do labeling studies and sort of what we call pharmacokinetic analysis, where we take the rat, we inject it, and we sac him at 4 hours, 8 hours. We do think we see, there's a thing called spectral imaging. Some of it is being taken up in the glomerulus, and we do see a little glomerulosclerosis. So we're wondering if there's some uptake in the podocyte, and there may be some small breaks in the basement membrane, but we don't know. We really don't know. And also, we think that it's being taken up in macrophages and monocytes and ending up in the spleen. We can find when the silica initially is in the liver and the kidney and the lung. And then over time, it goes down on all three sites. There's a little bit of an increase in the spleen, and we can see it and measure it in the urine. So it's getting through to the urine, but exactly how, I don't know. And over time, it disappears from the kidney. But the kidney disease has been triggered and injured, and that injury seems to progress. So these are, I'm hoping that there'll be another grant on this to figure this out. Yes?
Are the gender differences that you see clearly just to occupational differences, or is there something more?
There could be something more. There's a lady in our group who just got an award, K award, and as well as an R01. There's one, because it looks like if people are exposed equally, women do worse. Sorry to say that, but there may be something going on gender-wise, and I don't understand it yet. And it's also being seen as children from some of these areas who are not working. Some of them have urinary abnormalities, at age 8. So there's some. So that makes me think. Of course, it could still be heat stress, and it could still be toxins. These toxins are getting into the drinking water. In Sri Lanka, they're linking the disease with shallow wells. So if you're living in an area where there's shallow wells, you're more likely to get the kidney disease. But all the workers there know it. So if you're living in a shallow well area, they drink less because they're afraid to drink the water. So they make the dehydration worse. So you don't really know. They're getting worse kidney disease, but is it because they're drinking less water or because shallow water wells carry toxins? They've been found to be high in silica, though. So maybe it's the toxins. Any other questions? You know, the trouble when you try to discover things is you get more questions that you can't answer. But that's part of the fun of it. Then you do more studies to try to figure it out. Yes.
The observation that how they're hydrated seems to make a difference, not the total volume, but
Yeah.
any thoughts on?
Yeah. There is some evidence that in some of the early studies that just giving water is not enough. You need to give electrolytes. And we know that like chronic hypokalemia can cause interstitial inflammation and injury. So maybe, you know, correcting the electrolyte problem is important. Some of them may be deprived. You know, one of the problems with heat shock is you get ATP depletion. And so giving replenishment fluids that contain glucose may be important. Yeah, I think the type of fluid is important. If you give too much sugar, though, you're going to get problems, and that is for sure. We even did a study with animals, and if you give like 6% sugar, which is like half strength of a soft drink, you still make kidney disease worse, and that's what the WHO formula for rescuing dehydrated kids is doing. So we think that, you know, we can learn from this that might make a difference in other areas of medicine. All right. Yeah. Oh, yes. Go ahead.
So what is the best animal model? Is it mice?
Well, we've only done studies in mice and rats. We're the only group that's been doing that. No one else has been doing any. Actually, back in the 50s, some people were giving silica to rabbits, but it was like ground up sand, and I don't know if it was, I wouldn't count that.
So chronic kidney disease with low potassium as opposed to high potassium, how does that, what's your hypothesis on why that's a common feature? Because that's so unusual.
Yeah, when you get dehydrated, what happens is well, first off, sweating, you can lose a lot of potassium through sweat. So that's probably the number one. But also, as you get dehydrated, you activate sodium, aldosterone, and so that will cause potassium wasting. And there's been studies showing there's like potassium wasting. I think it's just activation of the renin-angiotensin system.
Can you prove that there's potassium wasting?
Yeah, I'm pretty sure someone has shown it, but I'm not 100% certain. People have been talking about it, but.
Yeah.
All right.
Thank you.
You're welcome.
Oh.